Hi everyone, thanks for taking the time to have a listen to my case study presentation. This is part of my specialisation process for sports and exercise specialisation with the college. We have to be involved in teaching the profession. I thought this was a interesting way to go about it. Okay. So we have to do a case study, one in first year and one in second year, and this was my first year case study and a presentation off the back of it. So patient MG was a 44-year-old male rock climber. He had a long-standing history, about 27 years history of climbing, and to quite a moderate level. He worked as a cardiac sonographer, and he had a recent new full-time role, and otherwise he was previously a ICU nurse for about 20 years or so. He has a wife and two children aged 3 and 5. Regarding his current history that caused him to present, about 3 months earlier he was bushwalking with his wife and 2 kids, and he ended up having to carry his kids about 3 kilometres, similar to the picture here shown, one smaller child, three-year-old, in the backpack, and the larger child not on his shoulders but on the front. This was the best Google photo I could find. That evening he had left shoulder pain while sleeping and was unable to lift his arm above his head due to that pain. He had pain limiting rock climbing for that 2 weeks or so, and it caused discomfort at work, but after about that few weeks it resolved and he was left with residual weakness. Now his main concern with climbing is that he was unable to return to his previous level. Currently only about grade 16, when normally he's about grade 25, as I mentioned before, quite a strong climber. He was concerned with this weakness and he wanted to know a diagnosis for that, as he was getting decreased enjoyment and frustration. His work-related weakness was causing him stress and anxiety, as he was due to begin a second role at a private medical imaging practice, and he was concerned he would sort of lose this new career opportunity. So, as sort of touched on just previously, his goal was to obtain a diagnosis. He was keen to improve his strength and confidence in his shoulder, return to pre-injury rock climbing levels, and make sure he could maintain his new career pathway and ensure that wasn't affected. So during our initial assessment, MG reported no pain. His previous pain was this lateral shoulder pain. It was consistent with an ache, about less than 5 out of 10. He had no pins and needles numbness, no referral, no click, lock or catch type symptoms. So regarding his 24-hour pattern of symptoms, this patient was reporting activity and movement related issues primarily around his weakness. So he was experiencing prolonged weakness with prolonged and repetitive abduction based movements with climbing, so coiling a rope, high lateral holds and Gaston movements, which is a pull apart type movement, plus external rotation type movements. Now this was primarily with his ultrasonography, and as you can see with this picture here, it shows how they have to hold the probe on the patient's chest while they do the scan. Now this can last approximately 10 to 20 minutes depending on pathology, and it can also be more difficult with patients with increased body habit, as they have to provide an increased amount of force to get closer to the heart to get a better picture. Our patient was reporting this was much more of an issue with those sort of patients. He didn't have any other problems with other activities of daily living, and reported his night symptoms had since resolved in terms of pain. He had no previous treatment. Regarding past history, the patient had no previous shoulder pain or history of trauma, no cervical spine pain or no thoracic spine history. His general health was good, and he had no other relevant medical history or comorbidities of note. Okay, so following our subjective, my main provisional diagnosis list consisted of rotator cuff related issue, the possible tear, a suprascapular nerve neuropathy, cervical spine issue, potentially like a C5-6 radiculopathy or adhesive capsulitis, considering I hadn't seen any of his movement yet. Okay, so into the objective. We began with observation. Now this was during our first assessment on the 15th of February 2022. We can note his left infraspinatus muscle wasting, which was quite obvious compared to his contralateral right side. Now, these were his other clinical tests as we went through his examination. Neurological exam was normal with normal elbow flexion, power and reflexes for C5-6. Cervical spine range of motion was no abnormality. Glenohumeral range of motion was generally good, nothing to take note of, and also suggest a adhesive capsulitis. Handheld dynamometry in neutral adduction for external rotation was significantly reduced, so 4.4 kilos on his left compared to 14.7 kilos on his right side. He was pain-free on his left, but he did try and use an adaptive movement pattern, and this didn't improve with symptom modification procedures. His internal rotation dynamometry was quite even, left to right. When looking at external rotation in side lying, he didn't appear to have any infraspinatus muscle activity just on palpation, and appeared to be trying to use a lot of teres minor to achieve the movement pattern. Patient-rated outcome measure, so his dash was 11.7%. It's not too bad, but into the work and sport module up around 25% and 37.5%, respectively, for disability. So I moved my provisional diagnosis list around to as shown, moving suprascapular nerve neuropathy up to the top. I couldn't discount a rotator cuff related tear, but I certainly didn't feel that cervical spine or adhesive capsulitis was playing a role. Now, when we're thinking around suprascapular nerve issues, prognostically, the correct diagnosis does certainly assist with determining recovery time, plus our initial management. As with a lot of nerve-related issues, delay in diagnosis is common with suprascapular nerve conditions, with often a delay in, say, 15 days to 2 years with regards to beginning of symptoms and with MRI assessment. So with treatment and planning, we went through discussing what I thought was going on, and we came up with a plan, particularly around MRI referral, to assess this. Now, when we're assessing or suspecting a suprascapular nerve condition, MRI is considered the gold standard when diagnosing a neuropathy. It's also valuable when it's assessing commonly described conditions that cause a suprascapular compression, particularly paralabral cysts, which can cause compression at the spinoglenoid notch or at the suprascapular notch. And additionally, a large retracted rotator cuff tear can cause traction and cause injury to the suprascapular nerve as well. So in twofold, it works quite well for us, because when we're considering our other differential diagnosis, large rotator cuff tear of sorts that might just cause cuff weakness, an ultrasound and an MRI are comparable when detecting full thickness rotator cuff tears, but the MRI is considered a gold standard assessment modality when assessing for suspected pathological rotator cuff disease. Okay, so patient went and got his MRI, and the report was appearances consistent with a Parsonage-Turner syndrome, but they also suggested there was a tear in the posterior superior labrum with tiny paralabral cysts, as well as a full thickness chondral loss at the inferior glenoid. So, as we can see on this slide A here, this T2 weighted sagittal image, supraspinatus and infraspinatus had this diffuse muscle edema throughout the bellies, as noted by the arrowheads there. On the coronal T2 on the next slide B here, you can see here the supraspinatus increased signal again, and a high riding humeral head, as noted by the arrowhead here. The paralabral cysts were what appeared quite tiny and difficult to see, and the glenoid change it's quite common in climbers, so it's probably not of consideration. Okay, so we'll roll through a bit of a timeline here because it got interesting in terms of management. So I caught up with him on the 15th. We organised the MRI on the 17th, and on the 17th day later that day, I made a phone call to him and discussed his MRI, and we discussed a neurologist review for opinion. So this is where it moved fairly quickly. After my phone call, he chatted with a local orthopaedic surgeon that he is a family friend of, who organised a cervical MRI, suggesting it was a cervical spine issue. And following this, also organised a referral to a neurosurgeon. He had the MRI later that evening, which found degenerative changes within cervical spine, with a prominent left C6-7 issue with impingement of the left C7 nerve root. So he then saw a neurosurgeon, and it was suggested that the disc issue will resolve, which was nice to hear. And he then organised nerve conduction studies with a local neurologist. The neurologist performed nerve conduction studies, which then gave the diagnosis of suprascapular nerve neuropathy, with the differential diagnosis or possible co-pathology being a parsonage-Turner syndrome, brachial neuritis type issue. We then caught up on the 1st of April, and then he had a subsequent nerve conduction study on the 6th of April, which suggested that the infraspinatus still had reduced amplitude on its muscle action potential, but the supraspinatus had innervation back to normal. So our final provisional diagnosis came back to suprascapular neuropathy, with the cause being a labral cyst creating pressure at the spinoglenoid notch. And this was mainly around the support by the EMG, with normal supraspinatus innervation at his second neurological visit in April. As you can see here on the slide, this is the area where we're considering these two little spots here and here, causing issue with the suprascapular nerve coming out through here. These are the other areas through here, which we have to consider, the suprascapular notch, but we'd consider more a potential supraspinatus issue as well if we're getting issues here. Now, at the neurologist review, it was suggested that the possible co-diagnosis of Parsons-Turner syndrome, the brachial neuritis, might be related to a previous laryngeal nerve issue. Now, after discussing this, the patient clarified with me that he had a previous laryngeal nerve palsy about 6 to 8 months earlier. The neurologist suggested this may have been related, and it might have been a predisposing factor to the suprascapular nerve injury. And prognostically, the neurologist gave him about a 12-month indication for nerve recovery, but clarified that there's potential that the nerve might not recover. And this, on looking into literature, was in line with it, in stating that recovery is usually quite favourable, with about 90% of cases recovering at about 3 years. What's generally prompted us within our practice is to ask a bit more along the lines of general health questions with regards to recent illness as well. Now, the other potential cause, as we were thinking through this issue, was back to the very second slide, I think it was, with the child on the patient's shoulders, whether that could have caused a traction injury to the nerve, considering it was so close to that. It potentially could have been a number of these things that could have caused this issue. Okay, so into our program. We began with posterior cuff loading, with the rotator cuff exercises due to their simplicity and the effectiveness of loading those muscles. Mechanism for assistance for these may have been through just strengthening, but also may have helped with reducing local shoulder pathology, such as a labral irritation, and achieved a subsequent reduction in paralabral cyst size and therefore reduction in nerve compression. We focused around retraction, as a scapular notch impingement can occur. It's been described in a weak or an unstable scapula, and there's also some evidence around scapular protraction, placing excessive traction or stretching on the nerve as well. Also encouraged him to continue with global shoulder strength and conditioning, considering he'd been limiting what he'd been doing over the past few months, and encouraged to continue climbing but maintain, ensure he wasn't performing any adaptive based postures to try and achieve some of his climbing patterns or techniques. Now, over time, we had trouble catching up with the patient, partly due to family issues, but we did have a few telehealth or phone calls to discuss progression, and we kept this fairly simple as we moved along. So from the previous slide, you can see our final consultation was on the 16th of September. Now, the patient reported he'd had significant improvement in his left shoulder, both in subjective strength, reduction in activity limitations, and his participation restrictions. And on examination, his muscle bulk and external rotation strength had significantly improved, with now displaying 11 kilos in external rotation versus 4.4 previously in February. Plus his external rotation, sorry, there's little images in the way there, but his external rotation in side lying had a 1 kilo, 11 RM, with improved infraspinatus activity. Whereas his right leg was still stronger at 2 kilos for a 15 RM plus. His DAS had significantly improved, with only very mild disability on the work and sport module at 6.25% and 12.5% respectively, considerably improved from 25 and 37% previously tested in our initial assessment. Now, you'll have to excuse my photography skills, but you can still get a good appreciation about our initial infraspinatus muscle wasting compared to our improvement over the 7-month period as this patient progressed with care. So overall, with activities, he built to rock climbing at a moderate level, grade 22 to 23, not quite up at his 25 yet, but he was improving well. He did report issues, as mentioned, with this Gaston type movement, similar to this photo here, where the thumb's placed down, the elbows flare outwards. And this may have been an issue due to that sort of outer range of posterior cuff loading, and just the muscles at that length tension relationship having less force capacity in that lengthened position. It may have just been he just also needed more continued strengthening over time. His sonography, he had maintained his new job, he had normalized his technique, and was not having issues there at all. Okay, so now I'd like to just chat a little on the clinical reasoning processing, which was interesting along this patient's pathway, the differentials as well, the program that we utilised, suprascapular nerve, and a bit around rock climbing and sonography, looking into a bit more research on that. So this case study provided an interesting process of clinical reasoning and diagnosis, with differential diagnosis selection potentially leading to other outcomes and interventions which might have been unnecessary, but also iatrogenic. The clinical reasoning and examination skills that we have are certainly of the utmost importance when the patients are displaying signs and symptoms of multiple diagnoses, or with different management pathways or treatment pathways. So when I was looking back in this initial phase of diagnosis, the imaging and the nerve conduction studies on the back of our physical exam were key to our diagnosis of suprascapular neuropathy. The negative neurological exam was an important finding with regards to correct diagnosis, and this combined with positive peripheral nerve weakness findings were key in lowering that cervical radiculopathy on the differential list. With our external rotation, it's driven by infraspinatus, supraspinatus and teres minor, and given we were unable to isolate, or we were unable to isolate rotator cuff muscles with specific tests, isolating for specific movements allowed for assessment of key nerve function. Now, given the patient displayed no other C5-6 neurological signs, be it motor elbow flexion, motor wrist extension, sensory deficit at C5-6 dermatomes, or bicep reflex, the nerve root compromise could be moved much lower on the differential list. Now, as that was sort of key information I used to determine the suprascapular neuropathy diagnosis along the way. Now, the next part into clinical reasoning, both on imaging and communication. So on imaging, the MRI of the shoulder is certainly the best way to visualize the degree of supraspinatus and infraspinatus atrophy. Look at soft tissue masses around the shoulder and assess for labral and rotator cuff pathology, plus to examine the course of the nerve as it goes through its bony prominences. Now, the gold standard diagnosis when diagnosing a suprascapular nerve pathology is EMG studies and nerve conduction or nerve velocity studies. Now, interestingly, this was a pick from our patient's second nerve conduction study with his left suprascapular nerve here and comparing to his right suprascapular nerve of much greater amplitude. Now, the other big thing that this patient did make me reflect on was our communication. I didn't quite see it going down the pathway it did with talking to a family friend, and then all of a sudden the patient's seeing a neurosurgeon. And it's made me reflect on asking more pertinently, is there anyone I need to write to discuss your care, or anyone else you would like me to get involved to help limit these sort of potential other issues that might come about through unnecessary care. Now, leading off the back of the unnecessary care aspect, so as physios, we can play a large role in preventing iatrogenic outcomes for unnecessary interventions. Now, had this patient had a potential C6-7 microdiscectomy due to misdiagnosis, he may have had unnecessary surgery leading to increased morbidity and expense. Now, mimickers of cervical pathology and lumbar pathology have been described in the literature, extensively highlighting the importance of correct differential diagnosis. Our reasoning and our examination skills are of the utmost importance when the patient displays these signs of multiple diagnosis and multiple management pathways. Now, once I finally got hold of the cervical spine imaging, it was really nice to see that the radiologist had made this note, and I'm seeing it more in our radiologist reports, that they're saying this should be correlated with the patient's clinical assessment in the first instance. So they're ensuring that it's not just a finding related just to doing a scan. Now, the Parsonage-Turner diagnosis, which is mentioned before, a rare idiopathic brachial plexopathy or brachial neuritis, a peripheral neuropathy. It wasn't initially considered within the list of differential diagnoses. That was something I learned a bit more about. It does warrant further investigation with formal EMG nerve conduction studies with a neurologist. The other interesting aspect of weakness I should have considered was probably an auxiliary nerve issue, reflecting his weakness in abduction, and it should have been considered, but with his history and mechanism description with no previous dislocation episodes, it would have been low down the differential list. All right. Okay, on to suprascapular nerve or neuropathy. The nerve is predominantly a motor nerve to supraspinatus muscle and infraspinatus muscle with no cutaneous sensory involvement. There's a little asterisk with that one. It does supply sensory innervation to the AC joint and the glenohumeral joint, and there is a normal anatomical variant in about 15% of patients where it receives cutaneous sensory fibers from the deltoid patch region, so similar to your auxiliary nerve, so you need to keep that in mind. It originates from C5, 6 and occasionally C4. It is well documented to have issues in overhead athletes, and frequently these athletes perform successfully at a higher level. It's particularly seen in volleyball at 12 to 33% incidence in a dominant hand, but also in baseball pitchers and female. There's a study looking at female tennis players, 52%, so quite a high level. And more common deficit is seen in that infraspinatus muscle. Now, there's various mechanisms for the etiology of this suprascapular neuropathy that have been proposed, which include repeated traction, microtrauma, ischemia of the nerve, and compression of the nerve by soft tissue, tumour or cyst. However, nerve injury due to repeated trauma is considered to be the main reason for development of this in these sort of athletes. There was another paper that suggested another proposal for the traumatic injury to the suprascapular nerve. Sandow and Ehrlich suggested that when the upper limb's abducted and externally rotated, the medial border of the supraspinatus tendon present at the spinoglenoid notch compresses the suprascapular nerve. Now, this repeated upper limb action then causes trauma to the nerve and injures it. Now, although overweight athletes have a greater risk of suprascapular nerve compared to the general population, it's unclear whether the extent of the shoulder use is associated with the risk of injury. And that the effect that they've suggested remains largely theoretical, because few studies have examined sport-specific functional impairment and the outcomes related to it. Now, as we discuss this neuropathy and the causes of the injury, imaging can play a big role. So if we can work out the location and a mechanism of injury, it can help with guiding factors for management. So different treatment strategies are required depending on where we may have a specific location or type of nerve injury. And most authors advise starting suprascapular neuropathy treatment with non-operative care of 4 to 6 months, unless the nerve compression is caused by a mass or a retracted tear. So these are quite nice little shots of obviously quite large cyst through this MRI here, and a nice little representation here, plus a retracted tear example in this drawing to the side here. Now, in such cases like that, early surgical intervention may be considered, because a delay in nerve decompression could result in incomplete restoration of muscle function. So if it's left for greater than 6 months, outcomes tended to be quite poor. If the non-operative treatment fails, surgical decompression was recommended, with common decompression sites being the suprascapular notch without a rotator cuff tear, suprascapular notch with a rotator cuff tear, the spinoglenoid notch with a paralabral cyst, or the spinoglenoid notch without a paralabral cyst. As with all patients, we need to take a patient-centered approach and discuss their options and encourage them to gain expert opinion to make an informed decision. So I think overall my key learning on this is just don't be afraid to image early and to gain a clear insight into what pathology might be playing a role with this patient's condition. So on a reflection about his program, had the patient been able to adhere to treatment sessions a bit more frequently, would have had an earlier progression and more optimal build-up of shoulder strength and function, but that's hard to know. A global shoulder program was prescribed with the patient's goals in mind, returning to rock climbing plus his work. And these principles from the back of this Swank paper in 2022 were mainly what I felt reflected my management around consideration of specific tissue involvement, and then integration of the kinetic chain, rotator cuff strength, and scapular kinematics simultaneously. Thinking around the scapula as part of the kinetic chain and encouraging him to return to that climbing aspect as soon as possible, plus considering his external rotation strength and internal rotation strength, and making sure they are lined up well. So when looking at sonography, it was interesting doing a bit of research around this. Now, they average, a bit of an idea of a sonographer's day, they average 12 to 13 scans per day, 30 minutes per scan, and a busy day they may do up to 16 scans. They tend to always learn with one hand and often find it difficult to change hands, even change a room setup. So with sonography, with work-related musculoskeletal disorders, around after about 6 months, 15% of them will have a issue like this, and after 3 years that increases up to 45%, and 10 years up about 72% have had experience of work-related musculoskeletal disorder, with a shoulder issue being the most common work-related disorder in these workers. So it's certainly an important consideration if you have a patient coming in to discuss this sort of thing, and importance of shoulder strength with these patients. Okay, so regarding rock climbing and shoulder injuries in the literature, in 2021, Buehler interviewed and examined 31 high-level climbers and found a point prevalence of 26% for shoulder pathology or injuries, and a lifetime prevalence of 77%. He found, compared to controls, they had a greater amount of labral and cartilage abnormalities. Now the changes that they had were also, they increased with increased climbing intensity, and this was also found in Jones's paper in 2008, with greater difficulty and frequency of climbing correlating to shoulder injuries experienced. Now, in 2022, Buehler looked at asymptomatic MRIs of elite climbers between 20 and 60 years old, and they found a higher prevalence of changes, so similar to other sports where we find changes in the rotator cuff tendon and subacromial bursitis, for instance, or bicep tendon. They did find a high level of labral pathology and articular cartilage changes, which is somewhat different to other overhead athletes, and this was suggested it might be due to shearing at the extreme sort of ranges that climbers put their shoulders in. Plus the equivalent of, say, body weight loadings at these extremes made range of motion, they might explain this prevalent labral pathology. Now, in terms of a climbing assessment, I didn't find much in terms of climbing assessment in the literature. There was one paper in 2009 which looked at a Cybex in a 90-90 position for ER-IR ratio of 0.8 roughly. Obviously I don't have access to a Cybex, but I utilize this position above in sitting, and I find it quite reliable and reproducible for myself. Certainly further research needs to be done in terms of rotator cuff norms with this sort of population. So my take homes following reflecting about this patient is that the reasoning we utilise in our reflection on our practice is certainly key and important to our progression. Considering potential overlapping of cervical and glenohumeral pathology, as this may steer our treatment pathways. We need to consider other conditions as well that might masquerade as a shoulder problem with an athlete. Communication, as always, is key, and we need to utilise this along with our reasoning above to help prevent any possible iatrogenic treatment or intervention for a patient. And then we need to recognise our gaps in the literature and try and utilise other work with other sports to help progress research in our patients who are potentially more on these fringe sports that are certainly developing well in Australia.